Usually, when we picture the fight against cancer, we tend to imagine these massive, high-tech interventions,
Right, yeah, the heavy artillery.
Exactly. We picture enormous radiation machines rotating around a patient or, I don't know, complex Vorvi drips in sterile rooms, surgeons doing incredibly delicate procedures. And, I mean, yes, those interventions are absolutely the heavy artillery. But sometimes managing this incredibly complex disease relies on protocols that sound almost, well, almost mundane.
Oh, absolutely. The everyday things.
Right. Things like strictly banning a cheerful bouquet of fresh flowers from a hospital room, or mandating that a patient use a simple sewing thimble for the rest of their life.
It sounds completely counterintuitive when you put it like that. I mean, you think, what on earth does a thimble have to do with fighting a lethal disease?
Yeah, it sounds like an old wives' tale or something.
Right, but those tiny, seemingly bizarre rules are actually life and death protocols. Once you understand the mechanical reality of what is happening inside the patient's body, it all makes perfect sense.
Which brings us to our mission for you today. Welcome to the Deep Dive. We are looking at a really comprehensive nursing presentation titled Care of the Client with Cancer, specifically from NUR 102.
It's a fantastic foundation.
It really is. And our goal today is to bypass the dense medical jargon and examine the literal anatomy of a rogue cell. We're going to track how it maneuvers and manipulates the body's highways and explore the highly calculated, intensely detailed ways healthcare professionals fight back on the front lines.
And to truly grasp those treatment protocols, you really have to start at the absolute foundation. I mean, we have to zoom all the way in on the microscopic pathophysiology.
Right down to the cell.
Exactly. Normal human cells are incredibly highly regulated entities. They know their function, they stay in their lane, and structurally, they actually reflect that order.
Okay, let's unpack this, because I like to picture a normal cell as like a well-behaved factory worker.
That's a great way to look at it.
Right, like they're following the blueprints exactly, keeping their workspace tidy, and they check in with their one single boss, which is the nucleus. Yes. A normal cell has a large, healthy cytoplasm, which is the fluid filling the cell, because it actually needs that space to manufacture proteins or do its designated job. It has a single nucleus acting as the command center, and the genetic material inside, the chromatin, is very fine and orderly.
But when a cell mutates into cancer, that structure just completely devolves, right?
Completely. The cytoplasm shrinks. It develops multiple enlarged command centers, so multiple nuclei and nucleoli, and the genetic material becomes coarse. It's just chaotic.
So it's basically a rebellious factory worker frantically building messy, chaotic extensions to the factory. They're completely ignoring the city zoning laws and taking conflicting orders from a bunch of different rogue bosses all at once.
That is a perfect way to visualize the mechanism. And, that concept of ignoring zoning laws leads us straight into the crucial distinction between a benign tumor and a malignant one.
Because people hear the word tumor and understandably panic. Of course they do. But benign cells, while they are abnormal growths, they are fundamentally local. They are cohesive.
Cohesive, meaning like they stick together.
Exactly. They stick tightly together, they grow slowly, and they are encapsulated, so they have a defined border. They might grow and physically push other tissues out of the way, which can certainly cause problems, but they do not invade.
Right. They aren't actively infiltrating the neighboring factory. They're just taking up too much space.
Exactly. But malignant cells, actual cancer, they operate completely differently. They grow rapidly, they obliterate borders, and they aggressively invade surrounding tissue. But looking at the microscopic traits, the single most dangerous characteristic of a malignant cell seems to be the fact that it is non-cohesive.
So lacks that stickiness.
Yes. Normal cells and benign cells have essentially a biological Velcro that keeps them anchored to each other and to their proper location. Malignant cells lack that Velcro. Because they are non-cohesive, individual cells can easily break off from the main tumor mass. And once a cell sheds, it can slip right into the bloodstream or the lymphatic system. That mechanism shedding into the body's transit network is the literal definition of metastasis.
Which explains a frankly terrifying statistic from the source material. It says 50% of cancer has already metastasized at the very moment of diagnosis.
It is a sobering statistic. Half the time, the enemy has already slipped into the highway system and set up shop somewhere else before you even realize the original factory is compromised.
That's just wild to think about.
But the spread isn't just random chaotic luck. That's the key here. These non-cohesive cells follow very predictable circulatory and lymphatic pathways. The physical layout of our blood vessels dictates exactly where the cancer will likely plant its next flag.
Let's trace some of those pathways because the predictability is fascinating. Like lung cancer, for instance, naturally spreads to the spinal cord, the brain, the liver, and the bone. Breast cancer goes to the lymph nodes, vertebrae, brain, and liver. Colon cancer targets the liver, lungs, brain, and ovaries. Prostate cancer moves to the bladder, bone, and liver.
If you think about the mechanics of blood flow, you can understand why. Take colon cancer. The blood draining from your intestinal tract goes directly into the portal vein, which feeds straight into the liver.
Oh, I see.
So mechanically, the liver is the very first capillary bed those robe Carlin cells get trapped in. Similarly, the lungs pump freshly oxygenated blood straight up to the brain. It is just an anatomical highway.
Wait, let me ask you this. If lung cancer likes to travel to the bone or brain, does that mean a patient might go to the doctor for a backache or a headache, only to discover it started in their lungs?
What's fascinating here is that that is exactly what happens. The secondary tumors are literal clones of the original. So a biopsy of a spinal lesion will reveal lung cells trying to grow inside a bone.
That is bizarre. Lung tissue just growing in the spine.
It's unsettling. But this is exactly why oncologists scan seemingly healthy parts of the body during a diagnostic workup. If they find a mass in the colon, they're immediately scanning the liver. They aren't guessing. They're following the map.
So they're playing a highly calculated game of hide and seek. And before they even do scans, they're looking for specific systemic alarms, right? The warning signs.
Absolutely. The physical assessment is crucial. They're looking for things like unusual lumps, thickening or sinking tissue, changes in warts or moles.
And unexplained weight loss, changes in bowel and bladder habits, indigestion, difficulty swallowing, or even white patches in the mouth.
And those physical warning signs are combined with a really deep dive into the patient's risk factors, age, sex, ethnicity, of course. But they also map out the oxidative stress from the patient's diet, exposure to certain viruses, occupational hazards, and tobacco or alcohol use.
So they build this comprehensive profile of vulnerability. But if the physical signs and the history point to a problem, how do they actually track down an invisible, non-cohesive enemy? Because, I mean, you can't just randomly biopsy the whole body.
No, you can't. That's why diagnostics rely heavily on specific markers floating in the bloodstream. They essentially use the blood as a radar system.
Right, looking for antigens.
Exactly. Proteins that cancer cells produce or trigger. For example, PSA, prostate-specific antigen, or CEA, carcinoembryonic antigen. They also track specific hormones or elevated enzymes like alkaline phosphatase.
And that alkaline phosphatase can spike when bone or liver tissue is being actively destroyed by metastasis, right?
That's spot on.
Wait, let me pause you there, because I understand looking for tumor markers. But looking at the source, I noticed that during the diagnostic phase, doctors also run tests for related anemias, things like a Schilling test for B12, assays for G6PD deficiency, or sickle cell tests. Why are we suddenly testing for inherited red blood cell conditions when we're hunting for a tumor?
That is such a crucial piece of the puzzle, and it often gets overlooked. You have to know the exact condition of the battlefield before you start dropping bombs.
Okay, that makes sense.
Cancer treatments, specifically chemotherapy, they put immense toxic stress on the blood and bone marrow. So if a patient has an underlying condition like G6PD deficiency, which is a genetic enzyme defect that causes red blood cells to prematurely break down under stress, or if they have sickle cell trait, throwing aggressive chemo at them could trigger a massive, fatal hemolytic crisis.
Wow, so you aren't just diagnosing the cancer, you are diagnosing the patient's physiological ability to survive the cure.
Exactly. The cure is incredibly harsh.
Okay, so once they've mapped the battlefield and confirmed the cancer, the physical extraction begins, and the surgical management is categorized into 3 goals: preventative, curative, and palliative.
Right. Preventative is removing suspicious tissue before it turns malignant. Curative is the attempt to physically extract every last rogue cell.
And palliative is when a cure isn't possible, but they remove a tumor mass simply to relieve pressure, reduce pain, or maybe open a blocked airway just to improve the quality of remaining life.
But as we established earlier, because these cells are non-cohesive, surgery alone often isn't enough. I mean, you can remove the main factory, but what about the cells already navigating the vascular highway?
The ones that broke off.
Yes. That requires a systemic weapon. Chemotherapy.
Chemo.
The whole goal of chemotherapy is to drastically reduce cell growth and tumor burden. It alters the cell's synthesis, its metabolism, and literally breaks its ability to replicate. But it's not just one drug. It is a massive arsenal with very different mechanisms of action.
Here's where it gets really interesting. Let's look at how they actually work, starting with a class called antimetabolites. This includes drugs like methotrexate or 5-fluorouracil. The mechanism here is brilliant.
It's basically a cellular Trojan horse. The cancer cell thinks it's eating a nutrient, like a vital building block to multiply, but it's actually swallowing poison that jams the replication machinery. It is a brilliant deception. But here is the brutal reality. Chemotherapy cannot perfectly distinguish between a rapidly dividing cancer cell and a rapidly dividing normal, healthy cell.
Oh, right, like hair follicles or stomach lining.
Exactly. The systemic toll is immense. Let's look at another class. Anti-tumor antibiotics.
Hold on. Antibiotics, I thought those were exclusively for fighting bacterial infections, not human tissue.
It's a really common point of confusion. These specific drugs like bleomycin or doxorubicin, they are originally derived from strains of bacteria, but they aren't fighting an infection. They are incredibly potent compounds that physically bind with the DNA of the cancer cell, keeping it from multiplying.
The cost to the body has to be severe.
Oh, it is. Doxorubicin, for instance, carries a very high risk of cardiotoxicity. It can permanently damage the heart muscle.
Oh, wow.
Furthermore, these are severe vesicants, meaning if the IV slips and a single drop leaks out of the vein into the surrounding tissue, it causes rapid tissue necrosis. The flesh literally dies on contact.
That is terrifying. Okay, so if the Trojan horse poisoned the rebellious workers and the antibiotics jam the machinery, the next class, plant alkaloids like vincristine and Taxol, it feels like they just shut off the power grid to the entire industrial park.
Yeah, that's a fair analogy.
Because these drugs cause intense bone marrow suppression. Right. The factory that makes red and white blood cells just shuts down.
That's precisely what happens. And then you also have hormonal therapies. This is giving high doses of synthetic hormones or antagonists, things like dexamethasone, DES, or Megestrol, to artificially starve hormone-dependent tumors.
But that completely disrupts the body's endocrine system.
Totally. It leads to profound side effects: extreme weight gain, insomnia, fluid retention, flushing, and massive mood shifts.
So if I'm tracking this, you are systematically poisoning the patient's DNA, shutting down their bone marrow, and scrambling their endocrine system. I mean, how does a human body physically endure a treatment that is fundamentally designed to be toxic?
They endure it because of a massive parallel medical effort to keep their baseline systems from collapsing. Treating the disease is only half the battle. Managing the collateral damage is the rest.
Like the nausea.
Exactly.
Yeah.
The nausea from chemo isn't just uncomfortable, it can lead to severe dehydration and electrolyte collapse. So patients are given powerful serotonin antagonists like granisetron to shut down the nausea pathways in the brain.
And they use biotherapy too, right? Things like synthetic interferons, interleukins, or hematopoietic growth factors.
Yes, to artificially whip that suppressed bone marrow into producing enough blood cells to keep the patient alive.
Which naturally brings us to the frontline defense, the nursing care. Because the doctors write the chemo orders, but the nurses are the ones actually managing a fundamentally crashing human system hour by hour.
Nursing in oncology is where pure science really meets human survival. Nurses have to be hypervigilant for what are called oncological emergencies.
What exactly are those?
These are sudden, catastrophic, life-threatening cascades caused either by the tumor's behavior itself or the sheer toxicity of the treatment.
Okay, you can't just drop a phrase like catastrophic cascade without unpacking what's actually happening. Take tumor lysis syndrome. What is that?
So tumor lysis syndrome happens when chemotherapy is almost too effective.
Too effective.
Yeah. It destroys so many cancer cells so quickly that all the toxic internal contents of those cells, massive amounts of potassium, phosphorus, and uric acid, are suddenly dumped into the bloodstream all at once.
Oh, man.
The kidneys become completely overwhelmed trying to filter out this toxic sludge, and that can lead to rapid kidney failure and lethal heart arrhythmias.
Wow. And what about hypercalcemia? The source mentions that as an emergency, too.
That occurs when cancer metastasizes to the bone. As the tumor physically eats away at the skeletal structure, it releases massive amounts of stored calcium into the blood.
And too much calcium is bad.
Very bad. It acts like a sedative to the electrical system of the heart and the nervous system. The patient becomes lethargic, their muscles weaken, and without immediate intervention, their heart will simply stop beating.
And the list goes on. There's spinal cord compression. There's DIC, disseminated intravascular coagulation, where the body's clotting system completely short circuits.
Yes. DIC is terrifying. It causes massive, microscopic blood clots everywhere while simultaneously causing the patient to bleed out because they've used up all their clotting factors.
Or superior vena cava syndrome, where a tumor in the chest grows so large it physically crushes the main vein, returning blood from the head to the heart. The patient's face and neck just swell dangerously.
Every single one of these emergencies requires immediate, highly specialized intervention. But the most common and perhaps most perilous daily threat a patient faces is neutropenia.
Yes, let's focus on neutropenia, because this explains the strange rules we teased at the very beginning of the deep dive. Neutropenia happens when the chemotherapy has so thoroughly suppressed the bone marrow that the patient's white blood cell count drops to virtually zero.
Exactly. The patient has absolutely no biological defenses left. Their internal armor is entirely gone.
And this is where the strict infection control rules kick in. Absolutely no fresh fruit, no fresh vegetables, and no fresh flowers allowed in the patient's room.
None.
So what does this all mean for the patient's morale? You're telling me your loved one is recovering from cancer, going through absolute hell, they're physically exhausted, and I can't even bring them a bouquet of roses to brighten up the sterile room or like a fresh apple for them to eat.
If we connect this to the bigger picture, you'll see why. Because the treatments obliterate the immune system, a harmless microbe on a flower petal isn't just dirt, it is a suddenly life-threatening danger. A healthy immune system effortlessly destroys the millions of common bacteria and fungal spores living on a flower petal or the skin of an unpeeled apple. But to a patient with zero neutrophils, a single fungal spore from a tulip can aggressively colonize their lungs and kill them in a matter of days.
Oh, wow.
The rules are ruthless because the margin of error is zero. Nursing care has to be fiercely protective, creating a literal bubble of safety while the medicine does its violent work.
That makes total sense now.
Yeah.
And that hypervigilance extends far beyond the hospital walls, too. When a patient eventually goes home, they are often navigating the world with a completely altered physiology. Let's look at specific cancers, like breast cancer recovery.
Okay.
Immediately after surgery, the patient is placed in a 45-degree Fowler's position.
Right. That specific angle uses gravity to promote fluid drainage away from the surgical site, and it really eases the work of breathing.
But the long-term rules are what really caught my eye. So much of the post-operative education is focused on preventing lymphedema, which is that severe chronic swelling in the arm.
Yes, because during a mastectomy, surgeons often have to remove the lymph nodes under the arm to check for metastasis.
And those nodes act as the drainage system, right?
Yes. Yes, they are the drainage system and the localized immune defense for that entire arm. Without them, fluid gets trapped, and the arm loses its ability to fight off even microscopic localized infections.
Which finally brings us to the thimble. The protocols dictate an incredibly specific set of lifelong rules. To prevent lymphedema complications, the patient must wear heavy gloves when gardening or cleaning. They have to shave with an electric razor, never a manual blade.
No blades, ever.
They have to obsessively use insect repellent. They can never allow a blood draw or an IV in that affected arm. And if they sew, they must use a thimble.
Because a tiny prick from a sewing needle or a minor scratch from a rose bush introduces a small amount of bacteria. For you or me, our local lymph nodes trap it, we get a little redness, and it heals. But for a breast cancer survivor without those nodes, that tiny prick isn't fought off. The bacteria multiplies in the stagnant lymphatic fluid, leading to a massive, potentially limb-threatening infection called cellulitis.
They're given a new set of rules because they are living in a fundamentally altered body.
Exactly.
We see that profound alteration with prostate cancer, too. First of all, the screenings need to start at age 50, checking that PSA level.
Yeah.
But if surgery is required, the recovery is intense. Patients often require continuous bladder irrigation post-op.
Mechanically, that involves running a constant flow of sterile saline into the bladder and draining it right back out.
Sounds uncomfortable.
It is, but the goal is to continuously wash away blood before it has a chance to form a clot that could block the urethra, which would be excruciating and incredibly dangerous.
And beyond the surgery, if they use pharmacological treatments like diethylstilbestrol, which is a synthetic estrogen, the impact is staggering.
Yes, it is.
If I'm tracking this, you are giving a man massive doses of synthetic estrogen to essentially starve a testosterone-dependent prostate tumor. That has to cause radical physical changes.
It absolutely does. The physical side effects include gynecomastia, which is the development of breast tissue, as well as profound hot flashes, fluid retention, erectile dysfunction, and potential incontinence.
It's a lot to deal with.
The emotional toll of these treatments is absolutely devastating. Nurses and families aren't just managing physical healing, they are guiding a patient through a profound loss of function, drastic changes in body image, and intense hormonal shifts. The psychological support is as vital as the physical care.
It is an absolute marathon. Even looking at lung cancer, the post-surgical care is relentless. Emphasizing respiratory recovery, nurses are constantly pushing the patient to use incentive spirometry.
Right, making them forcefully breathe into a device to pop their compromised lungs fully open and prevent pneumonia.
And they are forcing the patient to exercise their legs and feet to prevent blood clots. They are meticulously monitoring the water-seal drainage in chest tubes to ensure the vacuum in the chest cavity remains intact.
Every single cancer type demands a bespoke, incredibly specialized battle plan. The treatment is not a monolith. It requires anticipating precisely how the patient's specific bodily systems will fail under the dual stress of the disease and the cure, and preemptively stepping in to brace those failing systems.
The scale of this fight is just staggering when you zoom out.
Yeah.
We started today by looking at the microscopic chaos of a single malignant cell, that rebellious factory worker who lost the blueprints.
Yep.
We traced how their lack of cellular Velcro allows them to slip into the bloodstream and ride the vascular highways to deeply predictable capillary beds. And we explored the incredibly intense counterattack.
A counterattack that balances the deployment of toxic systemic cellular poisons with the hypervigilant, painstakingly detailed protective care of the nursing staff.
Exactly. It's a razor-thin tightrope walk. You are trying to poison the disease without losing the patient. And managing that collateral damage is exactly why rules as strict as denying fresh flowers or relying on something as simple as a sewing thimble are just as vital as the chemotherapy itself.
You know, examining the sheer adaptability of this disease leaves me with a final provocative thought.
I wanted to hear it.
If a single rogue cell can so effectively adapt, disguise itself from our immune system, and manipulate the body's own vascular highways and resources to survive our most toxic treatments, perhaps we should view cancer not simply as an alien disease to be eradicated.
Okay.
Perhaps it is an incredibly complex, distorted mirror of our own biology's fundamental drive to survive at any cost.
Wow.
And if that is the case, how might this perspective shift the future of medicine? I mean, if we understand the mechanisms perfectly, could we eventually move away from waging a toxic war on the body and instead find a way to chemically reprogram those rogue cells back into harmony with the whole?
Reprogramming instead of destroying. That is an incredible thought to end on, because as long as we are forced to wage a war, there's always going to be devastating collateral damage to manage. Thank you for taking this deep dive with us. Take care of yourselves, and we'll see you next time.